Hello, I'm Michael O'Toole, and welcome to our Digital Health Pioneers podcast. I think we can all agree that healthcare is struggling. We've got major shortages in staffing. On top of that, we have a higher demand for healthcare services, and it's a turning point for us. So, one of the ways that we can solve that problem is through the use of technology. And that's really what this podcast is about, is how are people using technology to handle this new demand with less resources. We do have some special guests from Piedmont Healthcare, and I'm really excited to talk to them about the way they've implemented virtual nursing, which is really impressive. They have implemented a program across their 23 hospital network in a very short time period, actually roughly 12 to 16 months. And you're going to hear from them today about how they did it, what their challenges were, what their successes were, and any advice that they would give to other nursing leaders who are on this track of implementing virtual nursing. The guests that we have on our session today, Stacey and Grant from Piedmont Healthcare. Welcome.
Thank you.
And I would like for them to do an introduction of themselves. If you could, Stacey and Grant, tell us your name, title, how long you've been with Piedmont Healthcare, and kind of what your role is in the organization.
I'll get started. My name is Stacey McGriff. I'm a program manager for the virtual health team for Piedmont Healthcare. I have been with Piedmont for 15 years. I'm a cardiac nurse by trade and started at Piedmont right out of nursing school. Spent some time on the clinical quality team, helping drive cardiovascular improvement. And then in 2020, took a position on the virtual health team looking at lifting new inpatient and ambulatory programs in order to support new services and bolster existing services throughout Piedmont Healthcare. That to date is still what I do. A lot of my time over the last 18 months has been focused on supporting the technical aspect of our virtual nursing program, which is probably a great segue for Grant to go ahead and introduce himself.
Wonderful. Thank you, Stacey. Hi, my name is Grant Reed. I'm the clinical manager of virtual nursing with Piedmont Healthcare. I've been with Piedmont, I guess, pushing 11 years now. I started off kind of like Stacey at the bedside. Spent about 5 years working in an ICU setting, followed by 5 years as a clinical manager of a progressive care unit, both at Piedmont Atlanta Hospital. And for the last year and a half or so, have been with the systems team and partnered with this group to launch virtual nursing.
Great. Well, it's really nice to talk to some nurses on the topic of technology and how we're engaging technology to improve patient care. Before we get started on the nuts and bolts of what you all have done, could you give me an overview of Piedmont Healthcare for some of our listeners that may not be aware, if they don't live in the state of Georgia, because it is the largest health system in the state. But Stacey, do you want to just kind of give us an overview of Piedmont size and scope?
Yeah, sure. So Piedmont Healthcare, we have 23 hospitals, 19 acute care hospitals. There are over 44,000 employees, I believe, well over 100 quick care, urgent care locations, a very large ambulatory landscape, both within physician practices, and then also within virtual offerings in order to really grow that landscape across Georgia. But the footprint really does span across the state. As you mentioned, it's the largest healthcare system within the state of Georgia, and it's just continuing to expand.
And Piedmont has had some significant growth over the last maybe 10 years when you were only 4 hospitals. But that was only maybe, 8 years ago, I feel like. And now you're up to the 23. So significant growth. Kudos to the Piedmont team. So quick overview of the problem that you were really looking to solve. So we know the solution was virtual nursing, but tell us a little bit about what the problem was at hand, kind of the pain points and your current state, that led you to a virtual nursing solution?
Sure, absolutely. Virtual nursing is such, as we've learned now, is such a large umbrella of tasks and activities. But really, at the crux of it, it's looking for a solution that we can support bedside staff in order to give time back to them and they could spend it physically with the patient doing those activities that require hands-on assessment, med administration, and other in-room activities that again require that face-to-face interaction. The nursing shortage, I think, has been talked about well before even I graduated from nursing school, has continued to be a pain point. And then post-pandemic, we continue to see just huge impact on staffing, contract labor costs, patient satisfaction, nursing retention, and we found a really great opportunity to provide a virtual resource to help, again, offload some of that task management that can be handled away from the bedside and still provide quality care to the patient and looking at increasing retention, patient satisfaction, and all those things that we mentioned previously. Um, when this was first brought up, I when we first went through kind of the initial channels of discussion, it was picked up pretty immediately by our leadership to say this is something that is not siloed to a hospital or a unit. This is something that could be a system impact to provide change and augment how we provide patient care. So as a solution, it seemed like a great fit. And from there, it was really tailoring down the activities to see where we could make the most immediate impact. And one of our primary focuses really early on was we know this will be impactful everywhere. How do we get this out efficiently across the system as quickly as possible?
Great. So it sounds like one of your recipes for success is that you had that leadership buy-in. Was that from, I'm assuming the CNO, but other executive leaders at Piedmont as well around this initiative?
Yeah. So it really was picked up by executive leadership over Piedmont Healthcare to say, this is something that we know can bring value to this organization. Let's quickly get a pilot in place. And within 60 days, we had been able to select a vendor, look at our processes, identify workflow, and have a 90-day pilot set up and even 141 rooms outfitted and ready to go to support this. Truly, with virtual nursing, you can leverage several different types of devices, be it an iPad, anything that would have two-way audio, video communication between the virtual nurse and the patient. But we really found that we wanted to streamline and make this as convenient as possible for the nursing staff. So rather than starting with an iPad or another mobile device, we focused that pilot on outfitting the rooms with in-room kits so that you call directly into that space and not adding any additional physical workflows to the bedside step. Primarily because that kind of takes away from what our ultimate goal is. And we wanted to really make that a focus out of the gate.
And it's you touched on a little bit there what the solution is, but can you give the audience an idea of what it is that you put in place? So it's inpatient, like for example, is it inpatient units? Is it what kind of how is the technology used in what specific scenarios and use cases, just so they can get an idea of what you all implemented. I feel like virtual nursing, it can have many definitions and span across ambulatory and inpatient, and so I just want to help our listeners kind of understand where you all have implemented it.
Yeah, absolutely. So again, with a primary focus being what is the broadest impact we can have with an efficient rollout to make sure that we're providing quality, but also what's the largest impact and how do we move quickly? And in doing so, we really isolated the med-surg population. I say that though, the definition that we use for med-surg is probably much broader than what you are typically hearing within an inpatient space. So our primary area of focus is inpatient med-surg areas, and those units essentially are every unit that is not intensive care or women's services, NICU, PICU, but really anything that would fall under a really broad med-surg umbrella. Grant, do you think that's pretty fair definition?
Oh,
I see you're not.
that's excellent. So we included specialty units considered maybe the step downs or progressive care units in some institutions. Here we call them progressive care units. And as we've rolled out, really seeing the positive impact of the solution has been exciting and something that we're really interested in sharing with a grander audience. So glad to be here.
And
Great.
that's not
Okay.
to say
Oh, go
we
ahead.
won't, I'm sorry, that we won't grow into other areas. But again, in order to be efficient and really have a targeted audience for this program, we chose that broader med-surg um, definition. The second piece to that is really identifying activities that will be immediately impactful, but making sure that we keep those also really um, I wouldn't say streamlined, but that we've identified exactly what the work is for this initial rollout so that we don't go outside of that scope and we can really hone in on the amount of time per activity that is going back to bedside and being able to effectively and objectively evaluate the impact. So along with defining population, we also whittled down to two very specific tasks that the virtual nurses will take on for the sake of this initial rollout, which is admission, including med reconciliation, and then discharge education.
Okay, great. So really your scope is very large because if you think about the 23 hospital enterprise and you're focusing on, deploying this technology in all units except for those kind of special, ICU and some of those others, you're really that's a large deployment. Um, Tell me, just to give me a visual, these nurses that are on the other end that are interacting with patients and staff at the hospital, where are they located? They're sitting at their homes? Are they sitting in a centralized location?
Grant, do you want to speak to that?
I would be glad to. So current state, we're all centrally located in a very near place to Atlanta, Georgia. Um, we did that for a couple reasons. We are a very quick growing department within a very aggressive timeline that Stacey was hinting at the very least. Our intention, like she said, is admissions and discharges, and we want to provide that scope that you described as broad and maybe described as very narrow at the same time or in even the same breath. But we did that on purpose to be able to impact our entire organization as quickly as possible and to provide a service at a very high level that could be very easily duplicated from hospital to hospital. But to Stacy's point, also looking at the impact on day one, our goal is to return a large percentage of a inpatient nurses day back to them so that it can be refocused on other modalities such as hourly rounding that we know will have meaningful impacts and that patient's perception of quality of care. So to answer your question directly, yes, we all sit on site. That is our intention for the foreseeable future. And as we build this team, I think there's something to be said to have in-person huddles and to be able to pivot with an inpatient team that may be hard to duplicate in other settings.
Great. And could you walk us through the process? So it sounds like two major tasks that you focused on with the virtual nurses, which is admission and discharge. Walk us through what that process looks like if I'm a patient at Piedmont and I'm admitted to one of these units that has a virtual nurse. What does that look like when I get admitted? And then maybe just describe what it looks like when I'm discharged.
Yeah, I'll be glad to. I'll pick a patient, call him Mr. Smith, just as a easy talking point. So Mr. Smith comes into the ED. He receives some information regarding virtual nursing. and preparing him for being admitted into the inpatient setting or as part of the preparation for that transition. Now, Mr. Smith gets transferred from that ED unit to an inpatient unit. He gets welcomed by the inpatient nurse and their team as he's getting settled. Vital signs are being taken. Given another spill. Hey, there's a third part of our team here on 3 East. It is a virtual nurse. This virtual nurse will be implementing part of instrumental and part of your admission and discharge process. Um, they will be with you in the next 30 minutes or so. At times, and we really prefer this engagement, we may pop in the stream, meaning virtual nursing, at the same time that the inpatient team is getting that patient settled, which provides an ideal opportunity for an introduction. So in that situation, if I was the inpatient nurse, I say, Mr. Smith, this is your virtual nurse. Hey, virtual nurse, it's not a great time. We're getting the patient settled. Can you come back in 5 or 10 minutes? That person to person handoff and awareness for Mr. Smith, the patient, can really help build that trust and rapport with the virtual nursing team. So I'll say it's been 15 minutes. Mr. Smith is now ready, been settled. The virtual nurse team comes back. We engage with the patient. First, they'll hear a sound. We'll introduce ourselves, give a quick ADET spill of what the patient can expect, ultimately confirming the patient's identity and asking for permission to move forward with the video connection. Because up to that point, it's audio only for the patient's privacy. We'll engage with the patient. We'll spend on average about 15-20 minutes performing an admission assessment, doing that medication reconciliation or review like Stacey was talking about. Coming to an end, we'll ask any questions, so pass any information on to the bedside team. We do a really good job using closed loop communication with the inpatient team, communicating any action items or ask. And at that point, we separate our interaction with the patient and complete that circle of communication with the inpatient nurse. And that concludes the admission interaction. Now let's fast forward. Mr. Smith's been here for, let's say, a week, and now it's time for discharge. The provider puts in the order. We get notified that the order has been placed for Mr. Smith to go home. At this point, we will do a chart review. We need to get to know the patient. Spend 15 minutes or so, sometimes a little bit more, a little bit less, getting to know the patient, preparing that AVS, the after visit summary, to be custom tailored to that patient. Next steps would be we engage with that patient. We share our screen so the patient can follow up with us as we go through the after visit summary, educating the patient on their primary diagnosis, their new medications, any maybe change of diet, all those aspects that we're aware of that are included in really setting that patient up for success with next steps once they leave the hospital. We call it the after visit summary. Once that's completed, we will round out this visit or interaction in a separate way as the admission. We will communicate with the inpatient nurse that the discharge teaching has been completed. You may proceed per your normal steps to discharge this patient from the actual facility.
Wow, that's super impressive. So in the room, you must have every room has some kind of screen and camera. And how are those outfitted in the room?
And I can speak to that. So while all of these activities are happening at the bedside, there's a technological component and some interface work that's been done in order to automate a lot of the notifications for the virtual nursing team and allow them to access the technology. So earlier when I referred to an in-room outfitting, um, essentially what is in each space is a 43-inch TV that serves not only as just the patient TV, but also serves as the monitor for the video interaction with the patient. And then the camera itself has a speaker and microphone on it that are really impressive in sound quality and ability to pick up and filter out some of the excess noise so that we can have clear communication. Um, Technological workflows that kind of marry into that bedside workflow itself. We do have an interface with our EMR and the vendor platform so that as orders are entered for either admission or discharge, they will generate a task list. So in a traditional bedside nurse staffing setting, we may be more used to, you know, Nurse Stacey comes in and you have 5 to 6 patients that you're caring for the day, or those are your rooms that you are in charge of as patients come and go. In this case, it really is task-driven mentality so that as an admission comes in, a virtual nurse can pick that admission up and go ahead and get started rather than waiting on just an isolated space. This allows Grant's team to be extremely efficient in working across care setting. Um, of note, there are, 2,700 sensors deployed across 17 of our acute care hospitals, and 10 of those settings are live. So there's a lot of moving pieces at any given time. Once they pick up that task, um, they will complete a chart review, and then when they enter the room, initially they have what's called kind of it's an audio only call. So the TV will switch over; it'll show my name, so that the patient knows who's speaking with them, and that sensor is engaged. They will introduce themselves, get permission in order to turn on the cameras, to speak back to what Grant was saying with if the nurse is in the room, being able to say, "Now's not a great time." So all of that happens without actually engaging with a video with the patient. Once permission is granted that the patient is prepared to interact with the virtual nurse, that is when the camera will actually physically engage and come down from the ceiling, and that video feed will flip over. So just like you're seeing me now, it would be the same. And I would start that admission or discharge process with the patient.
Wow, that's really, I'm sure nurses that are listening are probably eager to come work at Piedmont to have that supplemental support. This the burden is so high on inpatient nurses today. It does seem like that can help alleviate some of that work, at least definitely for admission and discharge. Um, Tell me a little bit about your outcomes, either from a cost standpoint, from a clinical standpoint, patient experience. Do you have enough information or data to share with our listeners how this technology has really helped Piedmont and their patients?
Um, so we have really positive preliminary outcomes. To give you an idea of speed at which this project has been running, so we actually started scaling um, a year ago from the initial pilot, and again now have 2,700 sensors installed, just over 1,600 sensors, meaning rooms that are live within the system. So with that in mind, a lot of what we've done to date has been looking at our data, but in a constant state of go live. So we're waiting to release anything concrete just yet, looking at timelines, and a lot of the metrics that we are evaluating require a little bit of extra time in order to get a really clear picture of impact. But anecdotally, we are getting a lot of positive feedback, and pulling the staff and having conversations both with nursing leadership and nurses at the bedside, along with the virtual nurses, because a lot of times they're the ones getting feedback directly from patients. Um, One of our CNOs had said very early on, this is one of the very first projects that you see an impact day one. It's immediately beneficial to the nurses to be able to take some of this off their plate, even as everyone gets used to new workflows. Um, that grace period of really adopting, knowing how to acclimate, and then use that time differently. It's a little bit different with this project because there's an immediate benefit to the staff. And Grant, do you want to speak to a little bit about that? I know that you do a ton of rounding at the air at or on the floors.
Yeah, I'll start by echoing Stacy's opening statement. We're seeing a lot of early indicators of very promising success metrics that we will tie to virtual nursing. But at this time, we will wait to disclose some of the specifics to a little bit more concrete data. Um, from a go live perspective, from a direct impact with virtual nursing, that's why I signed up for this. 5 years prior to this, I ran a 42-bed inpatient unit. Was the COVID unit for a whole year during the pandemic. Um, Ultimately rebuilding that unit post-pandemic with my team to a place of relative stability, seeing this opportunity, or void, I should say, between kind of the standard of nursing prior to the pandemic and post-pandemic, uh, standard of excellence that we've been able to achieve, and saying, "Well, what's next? What's more?" At the same time, your technology has advanced to a place where something like this is actually an option to install in every patient's room. And as Stacy's earlier point, that makes a difference. This is a piece of technology that we, from a distance, can pretty much own and operate. There's no pushing in a cart or removing a cart, which takes me to my point. Post go live rounds, which that's what we call whenever we go live with virtual nursing in a facility. Probably the most consistent and feedback that's rang the most true to me was hearing from, the charge nurse that pulls me aside as I'm trying to go to the next unit, that says, "Grant, do you realize the impact that this has made for nurses whenever we're getting 3, 4 admissions, over a period of time across 2 different nurses?" And that period of time can be 30 minutes, 15 minutes, or sometimes that one nurse is getting 2 or 3 admissions within an hour period of time, or heaven forbid, they come up at the same time. To have that burden of that admission paperwork being done by another member of the care team, virtual nursing, has been a significant burden off of the inpatient shoulders. And I'll leave it with that one example. There are so many examples from the inpatient units about how this has impacted their workflow. With all the positive, I will say that embracing a new member of the care team for an experienced inpatient nurse does not come with some challenges. This is a new form or a new model of inpatient nursing. And probably discharges would be that place where a lot of those experienced nurses say, I got it. This is my patient. I'm the expert here." And what we did early on to help us get over that hump was to challenge nurses to, "Hey, take 10 minutes. We know you don't have it, but take 10, 15 minutes out of your day. Come witness how we do discharges as a virtual nursing component of this team." Um, One charge nurse from one of our early go lives actually walked out of that interaction saying, I understand why now. My preference now will be virtual nursing to do discharges because I don't have the time in my day to thoroughly cover every aspect of an after visit summary like I just saw done. And that is the consistent outcome that we hear from inpatient nurses. And I'm going to jump into a separate topic very quickly, but I think it correlates nicely with this question is, what do patients think about virtual nursing? That was something that, coming into it as an inpatient nurse, inpatient leader for 10 years prior to this, I was confident with what the literature had shown and proven, but still pretty on the fence about what our patients in Georgia would actually think about this. Retrospectively, patients love it. And the defining difference, or why they say, "I actually would prefer a virtual nurse to help with this part of the admission or this part of the discharge," is the time that we can dedicate uninterrupted to completing the admission process, or to educating on the discharge, that after visit summary information. It's just different. We don't have interruptions. This is our bread and butter. This is our sole focus in this department, is to be experts in the admission and discharge process. We don't have patients' bed alarms going off, or phones ringing requesting pain medication, or all the plethora of other examples that are common distractors of an inpatient nurse.
That's great. One thing I'm super impressed with is the speed at which you implemented so broadly. So, if you could just talk through what your implementation plan looked like. It sounded like maybe there was some kind of pilot and then it expanded, and maybe talk a little bit about that, piloting and scaling this.
Yeah, absolutely. I spoke briefly to it earlier, but really one of the key drivers here really was exceptional leadership support, and their challenge for us to, as a team, to vet a vendor quickly, set up a pilot quickly, look at those evaluations at the end to say, okay, does this look like it's going to have the benefit that we think it will? If so, how do we do this quickly? And I think that we probably had 10 iterations of the initial rollout schedule. And okay, if we can do X many beds in this amount of time, then how do we roll from facility to facility? Um, One of the things that benefited us with the pilot, because we were charged with moving quickly, we chose 141 beds between 3 different locations. And we said, okay, what do you think is the best way, or what vendors do you want to pull in locally to help us get this done and move from room to room to room? And we found that with partnering with one vendor that could contract out the network needs as well as provide the TV and really um, simplify that process, we were able to move quickly and go really outfit from a technical perspective about 6 rooms a day, knowing that there would be some ebb and flow to that. And based off of that schedule, we really just rolled out to say if we had 4 to 5 teams running at any given time, outfitting, what would that look like from planning, outfitting, and then um, putting in the equipment and then rolling off to Graham's team. So we had this pipe dream schedule that was on my fridge for a long time.
Understood.
Um, Truly, I think when we replaced my fridge recently, did that come down? That we were able to have several weekly and sometimes daily touch points between the technical outfitting teams as well as Grant's team and the overarching virtual nursing oversight team to say, where are we? Identify problems quickly, make quick pivots, and also adjust as needed. And I think one of the reasons truly I had on my fridge outside of reminding myself where we were at any given time was a point of pride in our ability as a team to maintain that speed and schedule and quickly address items as they arose and find creative solutions. The biggest challenge, but something that our team really did very, very well, was looking at maintaining the step before. And what I mean by that is if we are in technical implementation and we have X many beds left, ensuring that that's communicated to Grant so that that next step is ready to launch as soon as, step 1 is complete. We can roll into preparing the sites operationally, ensuring that they have all the collateral information and education to provide to patients, and then rolling directly into TDR and go live. So at any given time, we had, I think at one point we had all 10 sites and some phase of planning, implementation, go live, post go live support, or eventually into steady state. And so again, point of pride and a big call out for the virtual nursing team. A lot of that is due to executive support of this team and for us being able to make quick decisions, but also at the entity level, the support and buy-in within nursing operations and within facilities and within field services, really that cohesive decision-making and planning was a game changer.
That is great. One thing before we end, I would love for you to tell what advice would you have to our listeners who are contemplating implementing virtual nursing, or maybe have it and it may not be as working as well as it should. What advice would you have given your experience over the last, I guess it's only been the last, 16 months? Is it?
But
Yeah,
essentially,
it's crazy that all of that got implemented across the enterprise that quickly. But yeah, tell us maybe some lessons learned or things that you would give somebody else advice on, other nurses trying to do this.
well, it's interesting because I think we've seen different programs kind of manage it differently. For us, it was more as how do we make our footprint as large as possible and then scale up in tasks. And I think that in a system this large, that there are so many things that virtual nursing can and will eventually be doing. Um, one of the things that I think helped us stay on track was really clearly defining the scope of work, as well as clearly defining the areas that are included and involved, so that you don't have it limits your moving pieces. There's enough moving pieces as it is to not overcomplicate. Our teams went and physically walked through every area that was going to be included within the pilot, as well as within the scaling process over the last year. I think that was um, imperative. Again, leadership involvement, we've talked about that, local buy-in, and frequent communication, as well as the collaborative team. Um, the IT part of me also feels it's always worth mentioning is planning for support. When you're scaling from or adding any additional equipment that you need teams to support, is ensuring that you have the time, plans, and the right people involved as those plans evolve to support additional equipment, as well as technical workflows.
Great.
Grant,
Grant,
did you
anything you would add?
I wanted to jump in there with a couple additional points, but starting off with that, I think, very concise statement that senior leadership is really important to support this. Their involvement from the beginning, I think, set the standard for how this was to be adopted across the system. I think early engagement with teams as far as proper planning before the actual implementation, like anything new, was absolutely vital. Meeting in person with the leadership teams that actually were responsible for the teams of nurses that were going to be engaged with this, everywhere from the managers to directors to chief executive leadership was involved, and I think really help provide a pathway to success. I think preparing a toolkit or an easy to deploy set of standard actions that are requested from inpatient teams in preparation for something like this, along with timelines, also allowed us to be ready for that day. And when that day came to turn on virtual nursing, it wasn't like the teaching began then. It was like, finally, it's here. We're so glad for it. We know what to expect. Now is time to truly collaborate and communicate as a team, um, for the benefit of the patient. To the point of collaboration, this is a two-way street. Communication has been absolutely pivotal to success. We see the most successful units, the ones that truly take us up on our offer, call our virtual nursing team lead if there's any questions. And there's always one-off situations in patient facilities, like hospitals, discussing those nuances early on so we can figure out how we can partner together to provide the best care to patients.
That's fantastic. Well, wow, you've really implemented quite a bit very quickly and obviously made a great impact both to the nurses at Piedmont as to the patients. One thing that stood out as you kind of spoke to us about your implementation, I don't know if you're familiar with Rogers' diffusion of innovation. It's one of the change management models that we use here at Coker, but basically there's 5 attributes. So if you want to be successful for a large change effort, which this is a large change effort, you want to first have it to be relative advantage. And I think Stacey, you and Grant both said the nurses, when you showed them what it was like to do a discharge, they immediately saw the relative advantage. So you kind of covered that piece. The second one is compatibility. So how compatible is the change with current workflow and so forth? And I love that you went and walked the rooms and you had this kind of pre-implementation toolkit where you spoke to the nurses about how it's going to work. And it sounds like all of those efforts have really helped it to kind of check the box on compatibility. I love that you checked off the third one, which is complexity. You really simplified by saying, these are the only 2 things we're going to work on right now, admission and discharge, right? You could have done other things, but you decided that those were the 2 and they were going to be the biggest impact. The last 2 is trialability, and it sounds like you definitely did that with the pilots and showcasing those pilots. And then the last one is observability, and that But you actually highlighted that one, Stacey, at the beginning of the podcast around observability is, can you see the benefit right away, or is there a lag in seeing the benefit, right? Because sometimes we implement stuff and they don't necessarily, you can't see the tangible benefit until maybe another week or so, but here you see it right away. So, I think that the way you all have implemented it, I mean, it's to a T, following the best practices around change management, which probably is why you all were so successful. Um, any last remarks that you'd like to add that we didn't get to mention today before we wrap up?
You know what? I think regarding overarching impact to this project, the team that worked together to make this happen, um, and the tools used to make this happen are really not only huge drivers of success, but it's interesting to look back on now and know that, in April of 2023, we were doing some site visits to look at some technology to see what we thought would be our best options moving forward, and seeing where we are now. It's really a great opportunity to get to share those successes with you. Um, Very proud of this team and the work that we've put in. But overall, extremely proud of the nursing landscape within Piedmont. They want to be innovative in order to not only um, assist with bedside staff, but with truly providing exceptional care. And this is just another, piece of the overall picture that they can now add to that, which is pretty exceptional.
I think Piedmont's commitment to excellence, in this case, through early adoption of a very innovative approach to inpatient nursing, utilizing virtual nursing, something that makes me very proud of. Thinking back to a year and a half ago, looking for examples that we could duplicate or use as a standard to help us establish best practices here at Piedmont. There weren't a lot of organizations approaching virtual nursing in this way. I think the pureness of the initial mission to make a positive difference in the lives of our patients through making a positive difference in the lives of the inpatient nurse has been something that has run very true for me.
Well, kudos and congratulations, Stacey and Grant, and the entire Piedmont team. And thank you so much for your time today, sharing your wisdom. I know our listeners will much appreciate it. And that will wrap up our session. Thanks, everyone, for joining the Digital Pioneer podcast. We look forward to talking to you again on another topic.
Thank you.
Thanks, Michael.
Thank you for joining us today. I'm Michael O'Toole, and don't forget to hit subscribe so you can hear future episodes of our Healthcare Pioneers podcast.